Start. We are live.
Good evening, everyone, and a warm welcome to everyone to this virtual webinar on New Year updates in Medical Oncology 2025. To start and to give the introduction and context setting, I would like to invite Dr. Ajay Sharma, who is medical oncologist, founder and director of AS Lifeline Cancer Care Hospital, Rohini, Delhi. Over to you, sir.
Thank you, Samar. Thank you, Ashish, and everybody present over here. Uh, in continuation to our the newer updates in the medical oncology, especially we feel the choose the field of lung. So we'll be continuing with the more updates which has been recently added in the treatment of the lung carcinoma. So to share the experiences and to share their updates, I have a panel of people over here. Uh, I'd like to welcome Dr. Romil, and she is a resident medical officer at AS Lifeline Cancer Care Hospital, New Delhi. And uh, Dr. Ashish Upadhyay, he is a consultant medical and hematologist in Kolkata. And Dr. Nishant Bhaskar, he is again he's a RMO, resident medical officer at AS Lifeline Cancer Care Hospital. He is in Darbhanga. And the one of the panelist is speaker is be closing remarks by me only. So there is some network issues with Dr. Romil. So if everybody is okay, so shall I start? I will be the first speaker to start with. Is my screen visible? No, no. It is visible.
No, sir, it is not. Now it is visible, sir.
Now it is
Okay.
visible, sir, but can you make it full screen?
Yes.
Yeah, it is. Now it is visible.
So the topic which I'll be covering is the CNS mutations in the EGFR mutated advanced lung cancers and the treatment options and the comparison amongst all these. So we know that the incidence of lung cancer, the non-small cell lung cancer, it accounts for 80 to 85% of all the lung cancer cases, and the most common mutation is the EGFR mutations. So this is a chart which is showing that non-small cell is 85% and small cell is 15% of the lung cancers. And if we see the commonest mutations are the EGFR mutation, 17%, and rest are the L, CRET, up to MET and BRAF mutations that range from 1 to 10%. The incidence of the EGFR mutation across the world, if we see, there is a variation in the EGFR mutation prevalence. It ranges from 15% in the Europe to 62% in the Asian population. So patients with the lung cancer have the highest rate of identified brain metastasis, and the incidences are more pronounced in the people who have a mutation in the EGFR. So these are the places where the brain metastasis can happen. Leptomeningeal metastasis, the dural matter, the subdural matter, arachnoid matter, and the subarachnoid spaces. So, this is a study in which 44% of the patients with the mutations of EGFR had a brain metastasis compared with the 22% patients with the wild type EGFR. And if we see the leptomeningeal has a poor prognosis and the survival is just 4 to 6 weeks, and it may have it may have a higher chance of having EGFR mutations rather than the wild type EGFR. So 20% of the small cell, non-small cell lung cancer patients have brain metastasis at the time of diagnosis, and 40% will develop brain metastasis during the course of the disease. So, what are the sites of the metastasis and how it affects the quality of the life? And this is the questionnaire in which the non-small cell patients with a single metastatic site was studied. If we see, the most common site is the adrenal gland, followed by liver, contralateral lung, bone, and brain is approximately 50% of the patients, they have a brain metastasis. So now, if we have a brain metastasis, there is a decline in the quality of the life, and as compared to the other metastases. So brain mets in the mutated EGFR, advanced non-small cell lung cancer, and TKI. This is our main topic for the coverage. And what we already know is that brain is definitely sanctuary site for the metastatic tumor cell, and it is protected by the blood-brain barrier. And 40% of patients with non-small cell lung cancer with EGFR mutations will develop brain metastasis, and EGFR TKI are also substrates for human blood-brain barrier reflex transporters to varying degrees, and the influences in the distribution of compound in the brain at equilibrium. And the question is that how to increase the efficacy of the drugs, and how to reach the intracranial efficacy, and which TKI we have to use and where to use. So, osimertinib, it differentially penetrates the intact blood-brain barrier in monkey brains in preclinical studies. If we see, the above, this drug uptake in the brain, the osimertinib has very well penetration in the brain as compared to the other molecules. So it has a higher brain concentration than other DKIs, and osimertinib dose, it basically the penetration, it depends upon the dose in milligram per kg. We reach the plasma maximum concentration in the plasma and in the brain. So if we see amongst all the drugs, these studies have shown that osimertinib has the highest brain penetrance amongst the EGFR TK we are studying. The osimertinib causes tumor regression in mutated EGFR brain metastasis in a mouse xenograft model. So, in this intracarotid arterial injection of tumor cell was given, and the mouse developed the brain tumor. And this is the confirmation of the tumor formation and target expression of the in the histopathological examination. And there is a tumor growth inhibition with osimertinib. We can very well see in the subsequent these slides. So osimertinib was distributed in all the regions of the brain in healthy volunteers. So subject 1, 2, if we see, there is a distribution of the osimertinib in the brain. It is equally distributed. The osimertinib achieves brain exposure in patients with mutation of the EGFR, advanced non-small cell carcinoma with brain mets, and regional distribution and binding of osimertinib on PET parametric images shows total volume of the distribution. So a brief about the osimertinib. Osimertinib, it is a irreversible binder to the relevant mutated EGFR kinase forms, like it binds to 19 deletion mutations L858R, has a prolonged PFS and OS relative to the first generation EGFR TKI. It has anti-tumor effects in patients who are harboring the EGFR mutations, both common and uncommon. And the important point which we have discussed earlier is it has a high blood-brain barrier penetrance, and the exposure to the brain is very much helpful in the CNS metastasis, and it inhibits the growth of the CNS metastasis in population who are EGFR mutated. How does the efficacy of osimertinib compare to the first generation TKIs in the treatment of non-small cell lung cancer with EGFR mutations differ? So this is the FLORA study. We are known, familiar with this study. So in this study, the majority of patients had metastatic disease, 95% patients with 35% having visceral metastasis, and 21% patients had a CNS metastasis. So the results, PFS was the direct measure of the drug benefit, and in patients with known or treated CNS metastasis, the progression-free survival was 15.2 months in osimertinib versus 9.6 in the comparator studies. So osimertinib had significantly longer OS than comparator EGFR TKI, and at 24 months, osimertinib 74% of the patients who were on osimertinib, and at 36 months, 54% patients who were on osimertinib were alive. So we see the median PFS in osimertinib is 18.9 months, and the median OS is 38.6 months. If we do the CNS analysis, the results were versus 15% patients receiving osimertinib versus standard of care in all patients. And in FLORA trial, osimertinib demonstrated a superior PFS benefit regardless of the CNS disease status at study entry versus EGFR TKI comparator. So this is the second table for the results. If this is showing only the CNS full analysis, if we see the number of patients on the osimertinib was 61 and the comparator EGFR TKIs were 67, and the median CNS PFS was not reached, whereas in the comparator it was 13.9 months. So the median CNS PFS, it was higher, significantly higher in the osimertinib arm as compared to the standard of care. So if we see this study, in this, it not only treats the metastasis, but it also prevents the development of the metastasis in the brain. So it included patients with and without CNS metastasis at trial entry. Investigator assessed CNS progression events. They observed in 66% of the osimertinib and 16% of the other comparator EGFR TKIs. And the patients who remained in the study on the treatment at 12 months, it was 70%, 24 months, 42%, and in 36 months, 28% of the patients who were on osimertinib, they were continuing to receive the first line trial drug, that is osimertinib. First line osimertinib, it delayed the need for the subsequent therapies, and 28% versus 9% continue to receive the first line trial drug at 36 months. Some light on the real world evidence of osimertinib with the CNS meds. It has a rapid intracranial response to the osimertinib without the radiotherapy. So we can delay the radiotherapy, or we can even defer the radiotherapy in non-small cell lung cancer patients who are harboring the EGFR T790 mutations. Few cases I will discuss. Case 1. There was a patient who underwent right middle lobe resection of the lung because of an early stage of the non-small cell lung cancer 9 years ago, and multiple nodules were there in the lungs on the CT 7 years ago, which was a recurrence, and there was EGFR L858R mutation in exon 21. Geftinib was the first line of chemotherapy for 2 years, 11 months. 3 lines of cytotoxic drugs were given. After two courses uh, of vinorelbine administration, a six-line chemotherapy was also given, and then patient has a back pain, and he was detected with the thoracolumbar bone metastasis. Radiotherapy was given to the this the lumbar spine, and bronchoscopy was conducted for the rebiopsy, and we found an additional T790 mutations in the exon 20. So at seventh line, osimertinib 80 milligram per day was administered, and the brain nodules were detected, and the patient had an ECOG PS of 3. These are the results. In 13 days, we found that multiple metastases at the baseline, complete remission of the brain metastases, except for one in the left frontal lobe. And it was very fast in the 13 days only we found these results. And in the right pulmonary nodule, there is a shrinkage of the right nodule uh, just in 5 days after the administration of the osimertinib. Case 2. A 76-year-old man with a heavy smoking history underwent a resection of the lung because of the early stage of the lung cancer 10 years ago. EGFR exon 19 deletion positive with he developed multiple bone mets 6.5 years after the treatment. Geftinib was given for 4.5 years, then followed by afatinib and some courses of chemotherapy like PEM, CARB, and bevacizumab and Tagafrev was also given, and developed pleural fusion. Uh, Pleurothoracocentesis was done, and there was an additional mutation T790 in this patient. So fifth line chemotherapy was osimertinib. The ECOG PS was 2 in this patient. So we observed that on day 10, after the administration of osimertinib was started, the brain CT images revealed the remission of the single brain metastasis, which was asymptomatic. On day 14, pleural fusion was decreased, and after a month, there is a shrinkage of the multiple lung mets and decreased pleural fusion, and there was improvement in the PS. He was converted from ACOG PS2 to 1, and there was a significant decrease in the pleural fusion. These are the images in which we can see pre-treatment and day 10. And on day 10, we can find the complete remission of the single brain metastasis just in 10 days of the osimertinib treatment. So it's not more than a magic, I will say. Observations after 14 days, decrease of the pleural fusion, shrinkage of the pulmonary nodules. After 13 days, 31 days, again, significant shrinkage of the multiple lung mets and decrease in the left side pleural fusion. A small case with EGFR mutated non-small cell lung cancer who are treated uh, here as a first line osimertinib without radiotherapy. Earlier, patient was in the earlier two cases, patient received osimertinib as a seventh line and in the fifth line, but here it is in the first line. So 74-year-old woman with no history of smoking, elevated CEA level. The CT scan revealed shadow in the upper lobe of the left lung and small nodules in the entire left lung. Clinical stage was stage 4B, and it was adenocarcinoma lung and EGFR 19 deletion mutation positive. So more than 20 brain metastases were detected on the MRI, but patient was asymptomatic. And the osimertinib first line 80 milligram once daily. First line treatment was started, and whole brain RT was deferred in this patient. So we see in the imagings, there is a 40 millimeter white shadows in the upper lung of the left lung, multiple bilateral small nodules in the entire lung field, and observations we can find complete CNS response. I told that there were more than 20 lesions in the brain, and after 5 weeks, they were disappeared completely. So again, I think this is a wonderful result which you can get in the brain metastasis with the osimertinib. Rarely we get such responses in other carcinomas, like any solid tumor with the brain mets. We treat with the radiotherapy, but I think adenocarcinoma lung with mutations, which we have discussed, L858 and T790 mutations, they respond wonderfully with the osimertinib, especially in the first line. But even we have seen the responses in the fifth line and third line also. Is treated with osimertinib alone in patients with newly diagnosed EGFR mutant and mutant non-small cell lung carcinoma. Uh, these are the characteristics. The chart in we can see the median age was 64. Mainly, the 50% rather were female and 50% were female. Never smoker were 25%. All stages were included, but stage 4 was the number 34. And they had diagnosis of EGFR mutation also, and they were treated with osimertinib between 2014 till 2022. And initial therapy was with osimertinib, and they had one at least brain metastasis during the treatment of osimertinib. So observation was baseline 2 months post osimertinib and 34 post month osimertinib. We see that the disease control was seen until 34 months on the treatment of the osimertinib. So these 36 patients who had a median interval from brain metastasis to the first line osimertinib initiation of 25 days, and the best objective response rate was 100%, and 2 year overall survival was 80%. The CNS progression rates at 1, 2, and 3 years post osimertinib were 21, 32, and 41% respectively. And local failure was estimated to be 4.7% at 2 years post osimertinib. So recent guideline updates, what they suggest, we usually follow the NCCN guidelines, and the NCCN guidelines says that EGFR exon 19 deletion or 21 mutations, that is L858R. Even if patient prior to the first line systemic therapy or during the first line systemic therapy, the preferred treatment is the osimertinib. It is a category 1 recommendation, and other recommended or treatment are also there in the this flow chart we can see. So with this, I conclude my talk here, and with the message that brain metastasis in stage 4, a very common finding as far as the metastasis is concerned in the non-small cell lung carcinoma. So not to forget about the mutations, always do the genetic studies, and if we find any mutations, so the first line of treatment with or without CNS metastasis is definitely osimertinib. And even if having brain metastasis, but the patient is asymptomatic, we can defer the treatment of this WBRT, and we can straight away start the treatment with osimertinib, and we can find the results like a magic within few days, I'll say. So thanks for all the patients, and no I'd like to hand over to Ashish or Dinesh, whosoever is there, to call the next speaker. Thank you.
Thank you, sir. Good evening. Am I audible?
Yes.
Just a minute. Are my slides visible?
Yes, sir, it is.
So, good evening. Good evening, everyone. There's some background noise. Sorry. Thank you. So, good evening, everyone. First of all, I would like to thank AstraZeneca and Ajay sir for inviting me. So, I'm Dr. Asif Patel, consultant medical oncology from ESI Joka, Kolkata. So, I'll be giving an overview regarding lung cancer. So, to start with the burden of the disease, as per the Globocon 2020, we know that in both sexes, lung cancer is the fourth most common cancer, and among males, it's the second most common cancer. Every year, around 50,000 new male patients get diagnosed with lung cancer, and another 20,000 female patients get diagnosed with lung cancer. If you see the recent change in the AJCC staging from 7 to 8 edition, then you can see that those tumor with T size between 5 to 7 centimeter has been upstaged from T2 to T3, and T more than 7 centimeter has been upstaged from T3 to T4. And the same entity has been upstaged from 2B to 3A. Disease with T3N2 has been upstaged from 3A to 3B, and T334N3 disease has been upstaged from 3B to 3C. The investigations required for staging are bronchoscopy, CT scan of thorax, PET scan, EBUS, EUS, medianoscopy, and MRI brain. The difference between CECT and PET scan for staging in stage 3 lung cancer, we will all know that lymph nodes with more than 10 millimeters short axis diameter have high prediction for malignancy. And with the addition of PET scan, we have increased the sensitivity from 55% to 80 to 90% with PET scan, and the specificity from 81% to again 85 to 95%. So PET scan has increased the sensitivity and specificity overall as compared to the PET scan, only CCT. So, what are the risk factors for occult N2? So, the risk factors are basically first is the tumor location, second is the size of the tumor, third is the higher SUV value. If you see the overall occult N2 lymph node metastasis correlation with respect to the tumor size, then T size from 0 to 2 centimeter has the overall lymph node involvement of around 4.8 centimeter. If we subcategorize this entity as per the location, then we can see on the left side for tumor from 0 to 2 centimeter, peripheral tumor had incidence of 2.9% and central had more than around 5 times of the incidence, that is 15%. Same for 2 to 3 centimeters tumor, we can see peripherally located tumor. If the tumor is peripherally located, then the incidence is 5.3%. If it is centrally, then it is 30%, 6 times. So we can see with respect to site size, and also we can see with higher SUV, that is more than 4, the lymph node occult N2 metastasis is 10.5% compared to 2% on. So these are the three risk factors for occult N2 metastasis. So how do we stage the mediastinum? So it can be either less invasive or invasive techniques. Like less invasive, the preferred one nowadays are endoscopic ultrasound and EBUS with biopsy. Invasive is mediastinoscopy. So you conventionally nowadays we go for EBUS and EUS for mediastinal staging. Even if EBUS and ES is negative, and if we are still having high suspicion for N2 disease, then in those cases we go for surgical mediastinoscopy. So when is invasive mediastinal staging indicated? So basically, as we know, as per the size, if the tumor is centrally located, if the T size is more than 3 centimeter, if there is extensive infiltration of the mediastinum without extrathoracic disease, then again patient with N2 disease, patient with N2 discrete N2, those patients with bulky N2, they need not undergo invasive staging because they can be straight away taken for multimodality treatment. And if the patient is having normal mediastinum on CT scan, then as per the PET scan, if it is positive, then we have to go. If it is negative, then we don't have. So if we see the mediastinal staging algorithm, then it goes as per the PET scan report. In the PET scan, first we have to see if mediastinal lymph node is involved or not. If mediastinal lymph nodes are not involved, and the patient is N0 disease with less probability of N2 on PET scan, then straight away the patient can be taken for radical treatment, surgery or radiation. But if the patient is N1 or having high suspicion for N2, then in those patients, we take the patient for EBUS and EUS. And as per the report, if it is positive, then multimodality treatment. If it is negative, then the patient is taken for radical treatment. In those patients with positive mediastinal lymph nodes on PET scan, we exclude bulky lymph nodes because those patients can be straight away taken for multimodality treatment. Those patients then which are not having bulky lymph nodes, in those patients we go for EBUS and EUS. If it is positive, then multimodality. If these are negative, then we go for surgical staging. And then as per the surgical staging, the treatment is fixed. So these are the different investigations which can roughly tell us what the different lymph node status that are accessible. And with this is the sensitivity with different invasive and non-invasive staging modalities for CA lung. So with CT scan, we could achieve a sensitivity of only 55%. Then came PET scan. It gave a sensitivity of 80%. Now with EBUS, EUS, and mid-density staging, we can go up to 94%. And VATS gives 99% for the lymph nodes that is on that side of VATS, on which side VATS is being performed. So if we see the evolution of therapy of lung cancer, then historically, it used to be divided only into entities, small cell and non-small cell. Then came the sub-categorization of the histology, that is large cell, squamous, adeno. And then now in the era of precision oncology, basically we classify as per the targets. So first we have to see if the advanced lung cancer, if it is targetable or non-targetable. For those lung cancer which targetable mutations, we go for different testings. And in those patients where targetable mutations are not patients, those patients are subcategorized based on the PD-L1 expressions. Those patients with high PD-L1 expression, more than 50%, they are high expressors, and less than 50 are less expressors. This again is a data by Nadia Holler et al., which took SEER data, and it basically, the influence of the study was from 2013 to 16. You can see on the left lower side, there is a drastic decrease in the mortality of lung cancer patients, both in male and female. The decrease from 13 to 16 was 6.3% in men and 5.9% in women. So what were the factors that were responsible for decrease in the incidence? The factors were, first, decrease in incidence. We can see the incidence also is decreasing with time. And second was the advent of targeted therapy. With a good number of targeted therapies, we are able to give better treatment to the patients, and outcomes are also increasing. So the mortality also is decreasing. Now, this is a wonderful slide which tells us the different treatment modalities that are available for CA lung, also with the FDA approval month and year. So it all began in 2006 when chemotherapy with bevacizumab for non-squamous came into picture. Then again in 2011, crizotinib was approved. In 13, erlotinib, 15, geftinib, then crizotinib. And now in 2020, we have more than 10 targetable mutations that can be targeted for lung cancer. And also we have different immunotherapies. Pembrolizumab came first in the year 2016 for second line. Then in 2017, again, Pembro with chemotherapy came. 2019 for less expression, and 20 we have both atezolizumab and nivolumab data with chemotherapy. So what are the molecular targets? So now we have data also. Last year only it was published. We say that those patients, we go for 12 marker NGS panel. They have OS advantage over less marker NGS panel. The reason being, even if the patient cannot be affordable most of the times for other rare mutations, because the cost of treatment for those mutations are on the higher side. But we are having multiple trials also. So if you get those patients, get that 12 marker test done, then what we can done is trial enrollment can be increased, and also the patient can be provide the benefit of this all treatment. So we all know as of now we are having around 10 targetable mutations: EGFR, AL, cross, RAF, MET, RET, HER2, NTRK, PIK3, ECRAS. These all are the different targetable mutations that are present in CA lung. Now, something about neoadjuvant and adjuvant chemotherapy for lung cancer. We all know for stage 1A patient, there is no benefit. Observation is required. For 1B and 2, with multimodality discuss on tumor board, adjuvant chemotherapy should be given in high risk patients. Those 4 centimeter high grade histology, neuroendocrine histology, vascular invasion, then pleural involvement. Those are high risk patients that get benefit with the chemotherapy. And stage 2, we all know adjuvant chemotherapy is required. And for N2 disease, that is stage 3, radiation also is added with chemotherapy, either sequentially or concurrently. Now, another important modality that is and the use of radiation with chemotherapy can be sequential and concurrent. We all know that for R2 positive disease, the extent of the surgery is very important. If there is residual disease in the patient in the form of microscopy, that is R1 disease, then in those patients, radiation is must. For R1 disease only, sequential chemoradiation can also be given to the patient. But for R2 disease, concurrent chemoradiation is usually given to the patient. Now, even after good initial treatment, around more than 50% of the patient they are failing. You can see 50 to 60% recover within 5 years. So overall outcome needs to be improved in even in resectable lung cancer. So for that only latest ESMO guideline, they say that adjuvant treatment should be given even in stage 1B patients, those with T size 4 centimeter and above. So this subset also got benefited with adjuvant treatment, and now we have approved adjuvant treatment in the form of osimertinib, alectinib, and atezolizumab for stage 1B patients as well. So the famous last meta-analysis which paved the way for adjuvant chemotherapy in CA lung, we can see at 5 years, the benefit was around 5.4%. The hazard ratio was 0.89. And in that, the same meta-analysis shows that both NSAT and adjuvant chemotherapy were equally good with hazard ratio of more or less similar 0.87 and 0.89. Now, the ADORA trial, the recently published ADORA trial, which took patient with completely resected stage 1B to 3A EGFR DEL 19 and 21 positive. Post-surgery, they were randomized into 3 years of osimertinib versus placebo. And we can see that with the introduction of osimertinib, the 3-year DFS has gone from 44% to impressive 90% with a hazard ratio of 0.20. So now adjuvant osimertinib is also doing wonder for lung cancer patients. Now, another study, IMpower 010 showed that for again high risk patient, that is stage 1B, T size 4 centimeter and above, patient with PD more than 1%, they get benefit with 1 year of adjuvant atezolizumab. You can see at 3 years, the DFS was 60% versus 48%. And we have ELINA trial in which 2 years of alectinib was given post-surgery. In those subset also 1B and above patients, again alectinib was given for 2 years, atezolizumab is for 1 year, alectinib 2 years, and osimertinib is for 3 years. Those patients also got DFS benefit. Now, something about radiation. We all know radiation modality is a very important modality in lung cancer. For early stage patients, we have SBRT. For advanced cases patients, we have conventional radiation. IMRT and IGRT are the usual techniques that are used for lung cancer patients because they are more conformal, the outcome is good, and the side effects also is less. SBRT for small size tumor T1, T size up to 3 to 4 centimeter node negative patient, they can be treated with SBRT. SBRT is high dose per fraction radiation. With less number of fraction high dose, the radical treatment can be achieved earlier. And this is specifically for smaller tumors. For larger tumor, we have concurrent chemo radiation in the form of IGRT technique. 4D CT planning is required because IGRT gating is required for lung cancer because lung tumor moves with respiration. And again, additive radiation also has decreased the overall side effect of lung cancer treatment. This was RTOC 0617 trial, which evaluated if any increase in the radiation dose or addition of cetuximab does any improvement to the lung cancer patient stage 3A and 3B. So we can see with the addition of cetuximab and with the increment of radiation dose, there was no benefit of such. So the standard treatment remains 60 radical CTRT with chemotherapy. So this we've already discussed for adjuvant treatment, and this holds true for neoadjuvant as well. So for neoadjuvant treatment, any tumor with T size 4 centimeter or node positive, they can be taken up for neoadjuvant chemotherapy or even IO therapy. Now, even Nivo plus chemo data is also there. So these are neoadjuvant, and those subset only get benefited with adjuvant chemotherapy also. For 1B, 2A chemotherapy is required, for 2B chemotherapy, and for N2 and above, we have to add radiation with chemotherapy. Checkpoint inhibitor, we all know that it's moving from advanced stage to early stage now. Pacific trial, stage 3 lung cancer, post CTRT, randomized to 1 year Durva versus placebo. We can see at 5 year, the DFS is 42% versus 33%. So durvalumab demonstrated 42.9% OS at 5 years. The historical standards which used to give us 5-year OS of around 15 to 25%. So this is around triple. double to triple. Now, the emerging treatment paradigms in CA lung, they are targeted immunotherapy. The target therapy approved, we all know that target therapy has done wonder, especially in the case of lung cancer, because for EGFR positive patient, we all know FLORA data, osimertinib versus first generation TKI, the median PFS went from 10 to 19 months. And with FLORA 2, that PFS even went to 25.5 months. So we can even add chemotherapy with osimertinib. With LX, again, the PFS for ALK positive patient went from 10.9 to 35.8%. And with Crown, and in Crown trial, that is with lorlatinib as compared to crizotinib, that PFS is not reached as of now. So that median PFS has increased from 9 to 10 months to 20 to even 40 months based on the which markers that the lung cancer is expressing. The other targets that are usually present are MET 3 to 5%, crizotinib, RET 1 to 2%, NTRK again less than 1%, then HER2 mutation, very important. It's HER2 mutation, it's not HER2 expression. For HER2 mutation, we have approved the M10 is there and HER2. So if we see the survival outcomes of targetable positive advanced lung cancer, then we can see historically the survival used to range from 8 to 14 months. It has now gone to even 35 to 50 months, especially for ALK positive patient. In Paramount trial, which used platinum doublet with pemetrexed, the median OS was 14 months. With different targeted mutation, like with osimertinib, it has reached to 39 months, alectinib 35 and still going, brigatinib 24 months, larotrectinib for NTRK and ROS 44 months, crizotinib again 19 months. So these are simple drugs. You just have to take them orally. They do come with side effects, but at least the ease of administration is there with wonderful outcome. The immune checkpoint inhibitor, we all know there are two types of immune checkpoint inhibitor, PD-1, L1, and anti-celiac blockage. These are two different checkpoint of our body. So when we block these two checkpoints, our immunity gets activated against cancer cells and they destroy the cancer. The different approved immunotherapies with age, it all started in 2015, in which second line Pembro and Nivo got approved. Then in 2019, then came Atezo, Pembro, then came Durva, first line. And now in 2021, Cemiplimab also came. Now, survival outcome with immune checkpoint inhibitor, we can see again historically 8 to 12 months. Now with IO, it has gone up to 22 and even to 30 months for high PD-L1 expression. You can see PD-L1 more than 50%. The median OS in Keynote 024 was 30 months. This same trial, Keynote 024, you can see that at 5 years, the DFS, the OS was 31% versus 16%. So at 5 years, 35% of the patients were alive, those who got treatment with immunotherapy. So checkpoint inhibition is now moving to early stages now, stage 1 to 3. We all know these are the trials we have evaluated in radical setting. Now, another new treatment, antibody drug conjugate, NR2 is there, TDM1 is there. These are nothing but chemotherapy drug linked with antibodies. The antibodies, they go and get attached with the antigens present on the cancer cells. The chemotherapy drug that get endocytosed and then release of that chemotherapy kills the cancer cells. So there is selective killing and the side effect is less and the overall response is also more. CAR T cell therapy, we all know in liquid malignancy, it is doing wonders. Now, people are evaluating its role in solid tumor as well. However, it's still investigational. So, to summarize, the management landscape is fast changing in non-small cell lung cancer. New therapies have a huge potential to improve survival, especially when detected in early stages. The OS has improved across various subtypes with molecular alterations. The use of oral pills over infusion in case of targeted drugs is an added advantage. Pulmonologists will play a huge role in early diagnosis, hence it is crucial to involve them in non-small cell lung cancer tumor boards. Thank you. And if there's any question, I'll be happy to answer.
Thank you, Dr. Ashish.
Thank you, sir.
It was a nice listening from you, and hopefully I will meet you once I come to Kolkata and you happen to be in Delhi. Please see me.
Yes, sir.
So with this, we'll continue to our next speaker, Dr. Romil. So
Sir,
she will be yes,
I had one question, sir.
yes, Ashish,
Regarding all your three cases, sir,
yes.
those three cases, would you consider osimertinib going to 160 milligram?
Uh, yes, definitely. We can consider that. But I think I
Your
always say
experience,
that
sir?
with 160.
Yes, sir.
I really don't have a very good experience because I don't go to the 160 milligram dose, but in the literature we can see that it has definitely very good penetration and the results are much better than the 80 milligram. But my experience with the people is with the 80 milligram also. So definitely we can increase the dose if it happens to be like constraints are basically Dr. Shish financial issues, I'll
Yes.
say. So if it is sponsored like or something, definitely I will like to put the patient on 160 milligram also.
Thank you, sir.
Thank you. Thank you. So over to you, Dr. Romil. Dhruv or Ashish, please unmute Dr. Romil. She is not having an access to her mic. Uh, Is Dr. Romil audible?
Yes, sir.
Dr. Romil, if you're not able to share the screen, should I share the screen?
Yeah, Ashish, Dhruv, you can share the screen. In the meanwhile, I'm just doing it for Dr. Romil also, but I think you start the presentation. Are the slides for Dr. Romil being shared? Can you see it in the your screens?
I can share this. I can see the screen, but can you just make it
Okay.
enlarge it?
Yes, I can do that, but it is visible.
Yeah, it
Dr.
is
Romil,
visible.
Think even I'm audible right now.
Yeah, it is audible now.
better come here.
Okay.
Wait. Okay.
Hello. Hello, I'm Dr. Romil. I'm currently working at AS Lifeline Cancer Care Hospital. First of all, I'm so sorry for keeping you all awaited. So next for next few minutes, we'll go through molecular biomarker testing in lung cancer. Before that, just have a quick look that how the burden of cancer has affected India. So according to Globocan 2020, we can clearly see that the 5.5% of the lung cancers, which is approximately 72,000, includes both the sexes and both the ages. It is the second most common cause in males, and it is placed at fourth, well above the stomach and esophageal cancer. Approximately 50% of patients with advanced non-squamous NSCLC have a driver mutation targetable with an FDA-approved agent or on a clinical trial. Here we can see that HER2 mutation, we have trastuzumab and deruxtecan. The importance of biomarker testing in non-small cell lung cancer, well, mutations who received appropriate targeted therapy have improved outcome. In the chart here, we can see the blue line where the targeted therapy showing the survival probability, which is well above the non-targeted therapy. The guideline recommended routine biomarker testing to guide the treatment decision in advanced NSCLC. We have some National Comprehensive Cancer Network and College of American Pathology who had conducted these researches. And the guideline states that testing of KRAS mutation as presence of a KRAS mutation indicates poor prognosis, and patients with KRAS mutation are unlikely to benefit from further molecular testing. Whereas European Society of Medical Oncology and have guidelines which includes the additional biomarker that should be tested based on the data that were not available uh, when the College of American Pathology guidelines were developed. So illustrating and the rapid progress in targeted treatments for non-NSCLC. We have methods of tissue testing in NSCLC. The first one is DNA sequencing, which detects the insertion, point mutation, and deletions. It detects the aberration in EGFR, KRAS, BRAF, HER2, and MET. The next one is RNA sequencing panel, which detects the fusion abnormalities and are more sensitive for LK, ROS1, RET, and NTRK. The last one is immunohistocompatibility complex and FISH, which detects the ALK and ROS1, and the IHS, which detects the ALK and ROS1, and it is comparatively easy test, faster but not reliable enough, and not sensitive enough to guide to the treatment. Test happens, and we'll compare them with the current modalities. So that once the preliminary diagnosis is made, the tissue goes from biopsy to the analysis. We have cytology, the liquid biopsies, from which we prepare the FFP blocks. Then the morphological assessment is carried out using histology and cytology, through which we extract the DNA, RNA, and proteins, and we get the analysis from them. To establish the diagnosis and determine the histological subtypes and biomarker testing, biopsy is very essential. For example, for histological subtyping, we have squamous or non-squamous. For biomarker testing, we have primary tumors and metastatic lesions equally suitable. Bone biopsies can be suboptimal due to decalcification and degradation of DNAs. Therefore, liquid biopsy comes in handy, and this is the one of another option for us. Test for EGFR, ALK, ROS1, BRAF, V600NE, and RET in all non-squamous NSCLCs. They use the broad NGS testing to detect the most mutation using least amount of tissues. And for squamous NSCLC, consider testing in young and the light smoker, or if the biopsy specimen is of mixed cytology. ctDNA testing has a potential to be applied across all the stages of NSCLC and throughout the treatment pathway. Like for the diagnosis and treatment selection, the next one is for monitoring prognosis, response to the treatment, and the progression or the relapse of the disease. ctDNA testing overcomes some major challenges associated with the tissue testing. It is minimally invasive for patients if needed. ctDNA in the bloodstream is comprised of DNA from all tumor sources in the body and capture both tumors. So heterogeneity and the tumor changes over the time. ctDNA testing will never replace tissue biopsy entirely, but could have a complementary role to support treatment selection in patients with NSCLC. ctDNA may be used to detect MRD after surgery in resectable NSCLC. ctDNA testing could identify a patient at risk for relapse and allow for appropriate intervention. Presence of MRD may be used to predict. And in front of us have a comparison of liquid and a tissue biopsy testing. For tumor tissues, it is invasive surgical procedure to obtain the tumor tissue, whereas in liquid biopsy, it is simple, where we draw the blood, generally 10 ml of whole blood. In tumor tissue, the serial testing is challenging and variable biopsy and the patient risk, whereas the liquid biopsy, it is minimally invasive procedure, allowing for easy serial testing throughout the course of therapy. Biologically, the tumor tissue correlation with histology and cellular phenotype is possible, whereas with liquid biopsy, direct correlation between ctDNA results with histology or cell type is not possible, though it is more reflective of tumor genomic landscape. Talking about the sensitivity of assay required, in tumor tissue, it is lower tumor cell content acceptable with sensitive techniques. And with liquid biopsy, it is a very sensitive method required as ctDNA may comprise less than 0.1% of ctDNA. Analytically talking, use of existing validated tissue processing and handling procedure, and in liquid biopsy, the standards of analytic ctDNA have not been established, and no guideline exists regarding the recommended performance characteristic of liquid biopsy. Evidence of clinical utility in tissue tumor, substantial evidence for initial targeted treatment selection and subsequent treatment after targeted treatment failure is advanced in NSCLC. And in liquid biopsy, it is less, but increasing evidence for initial targeted treatment selection and subsequent treatment after the targeted treatment failure is advanced NSCLC. Here in front of us is a model diagram for multiple genes involved in NSCLC. A single gene reflex testing or multiple gene testing by NGS. There are certain advantages of NGS. As the number of clinically actionable biomarker had increased, the ability of evaluate to all known molecular alteration in single test has given NGS a major advantage. If one or few molecular markers are needed, then the higher cost and longer turnover time is required versus a single gene. And if the molecular markers are many, then the cost is reduced, shorter turnover time and lower tissue requirement versus single genes. The techniques and molecular landscape in NSCLC. We have in front of us the technique used frequently for mutation detection. Yeah, these are the molecular landscape of non-small cell lung carcinoma with the available treatment option. And EGFR mutation in lung adenocarcinoma. We have sample types used for EGFR mutation testing. FFP sections like frozen or alcohol fixed specimens can be used for PCR-based assays. Cytology samples are also suitable, and cell. So, the summary of studies of the concordance of EGFR mutation in primary versus the metastatic tumor in the same patients were done, and discordance between the EGFR mutation and status in primary tumors and corresponding metastatic sites are rare. EGFRM test in early lung cancer. Here, NCCN recommends EGFR testing in early stage of NSCLC. And consider adding molecular testing for EGFR mutation to be performed on diagnostic biopsy or post-surgical resection sample to ensure the EGFR mutation. Results are available for adjuvant treatment decision and for patient with stage 1B and 3A NSCLC. There are certain advantages of NGS over PCR. Like the study showed that 48.6% of EGFR X20 mutation identified via NGS are missed by the PCR. And out of the 17 most common EGFR X20 mutation variants, only 4 can be identified via PCR. ALK rearrangement in NSCLC. In most of the cases, ALK IHC is 93 to 100% sensitive and specific compared to FISH. Whereas the false positivity rate is 0.1% with FISH. IHC is less expensive and hence more widely adopted. Then the ROS1 rearrangement in NSCLC, we have the algorithm in front of us, which is for predicting the genetic testing in ROS1 in advanced NSCLC in a routine practice. And detection of the elevated ROS1 protein levels by immunohistochemistry may provide the cost-effective screening, prior to which confirmatory FSIH testing is. BRF mutations in NSCLC. We have the BRF V600E mutation presents in more than 50% of BRF mutation cases and is thought to be more prevalent in smokers. Non-V600E mutations such as V600K, G466V, and G469A are less prevalent and occur in approximately 17% of patients with BRAF mutation. So overall, a BRAF mutation occurs in 1 to 5% of patients with NSCLC and most commonly in adenocarcinomas. The method for detection, while not widely recommended, ICH and PCR are generally accepted method for single gene BRF testing, and NGS is generally used for multiple gene test in panel. Let's see c-MET receptor tyrokinase and MET exon 14 skipping mutation in NSCLC. Normal role in embryogenesis and wound healing in cancer, METX14 skipping mutation cause in-frame deletion of the juxtamembrane domain, resulting in the increased stability and constitute the kinase activity. It comprises around 3 to 4% of non-squamous NSCLC and 20 to 30% of sarcomite cancer. So we can say that the majority of METX14 skipping mutation can be detected with the DNA NGS, but increased sensitivity with RNA NGS. The method for METX14 mutation detection ICH is not recommended, and also FISH is not recommended. PCR, it has design dependent, and RNA has technical consideration. So we can say that the NGS has design dependent, potentially detect the many mutations, and RNA it is most sensitive. RET receptor tyrosine have normal role in neural and genitourinary development. In cancer, RET gene rearrangement give rise to chimeric cytosolic proteins with constituently active RET kinase domains. So let's say that 1 to 2% of non-squamous NSCLC and 10 to 20% of papillary thyroid carcinoma. We can say that the majority of RET fusions can be detected by DNA NGS, but increased sensitivity with RNA NGS. There are methods for RET fusion detection, like IHC, FISH, and DNA and RNA NGs. It has certain pros and cons. From the table in front of us, we can draw the conclusion that the majority of RET fusions can be detected with DNA NGs, but increased sensitivity with RNA NGs. Then there is testing for NTRK fusions as well. We have certain options from ICH, RNA, or DNA NGs, FISH, and RT-PCR. It has again advantages and disadvantages, with each RNA NGs most sensitive and reflexing to NGs and ICH, reasonable for NSCLC due to low prevalence of NTRK fusion. It is important to qualify negative results limiting sample or testing. The method for RET fusion detection, again, the majority of RET fusions can be detected with DNA NGs, but increased sensitivity with RNA. This guy, okay, we have. For methods for NTRK and TRK fusion detection, we have again the ICs and FISH and NGs. We have advantage and disadvantage in front of us. So it has potential to fusion partner and positions are defined, where the RNA NGs are most sensitive, but the longer wait time for the result and cost. HER2 mutation in NSCLC. In HER2, it presents 3 to 5% of adenocarcinomas and mostly exon 20 in frame insertions. In NSCLC, HER2 mutation and amplification must be identified using an NG's DNA bank. We have 2022 treatment paradigm for molecular biomarker, positive advanced NSCLC. Okay, and PD-L1 antibody clones, IHC platforms, and scoring system in lung cancer. In PD-L1 testing, we have different antibodies used like SP263, 22C3, 288, and SP142. A different scoring system is adapted depending on the antibody used to detect PD-L1. The biomarker for immunotherapy in NSCLC is a controversial topic, and PD-L1, we can say that the sole current biomarker able to guide immunotherapy. TMB is a former marker for response, but not currently in use. And LG3 is possibly related to resistance to immunotherapy and is being studied. So according to this, we can draw a conclusion that the biomarker testing in NSCLC has evolved from a single gene to multiplex testing. Multidisciplinary meeting help in better understanding of sample and test requirement. Samples should contain adequate tumor content, at least 10%, to prevent delay in processing. An ideal TAT is 2 week, that is approximately 10 working days. High throughput platforms such as NGs can be used to screen several genes at a time to provide result within the estimated time. Then the oncology recommend broad molecular profiling to identify rare driver mutations for which effective drug may be available, or to appropriately counsel the patient about available clinical trial. Broad molecular profiling is a key component of the improvement of care and the patient with NSCLC. Okay, thank you so much. And now I'll ask Dr. Ajay sir to please carry forward.
Thank you, Dr. Romil. It was nice listening to the biomarkers and the journey towards his relation to the treatment. So, I'd like to request Dr. Nishant Bhaskar to please show to please start your this presentation.
Good evening, Dr. Ajay sir, and good evening to all our respected sir and our webinar team. Is I'm audible?
Yes, you are audible, sir. Can you enlarge it, your presentation?
Yeah, now it is okay.
So actually, you need to open a slideshow. Slideshow option is there. So, in the right hand side down, if you see there is a cup is made. So click on that cup.
नीचे नीचे सबसे नीचे जाओ, सबसे नीचे निशांत, हाँ जो वॉल्यूम का है उसके साथ देखो एक।
बाजू में जो कप बना हुआ है ना, हाँ, प्लीज क्लिक ऑन इट।
हाँ,
या
Good evening, Dr. Ajay sir, and good evening to all my respected sir and our webinar team. Myself, Dr. Nishant Bhaskar. I am RMO at AS Lifeline Cancer Care, second campus, which is in Darbhanga now. I would like to start with my topic. My topic is on real world evidence, osimertinib as a standard of care in the management of EGFRM mutation in NSCLC. First of all, I would like to start with its introduction. In patient with EGFR mutation, PFS improves after treatment with EGFR, TKIs, and with cytotoxic chemotherapy. Osimertinib, it is an irreversible third generation EGFR tyrosine kinase inhibitor, which is demonstrated as a clinically meaningful improvement in median progression-free survival, in which we can see MPFS, which is 18.9 month versus 10.2, and hazard ratio, which is 0.46, and the range is between 0.37 to 0.57 in the phase 3 randomized FLORA trial. Overall, survival median and OS, which is 38.6 month versus hazard ratio 0.8, and which made osimertinib as a best treatment option for patient with untreated EGFR mutant NSCLC. Osimertinib versus comparative EGFR TKIs as first-line treatment for EGFR mutation in advanced NSCLC FLORA, in which a final overall survival analysis we can see. We can see here a FLORA double-blind study design in which a patient with locally advanced or metastatic NSCLC here is a key inclusion criteria which are the age which is equal to 18 year or more than 18 year, which is equivalent in Japan, which is 20 year or more than 20 year. WHO performance status is 0 or 1. X19 DEL and L858R, which is enrolled by local or central EGFR testing. There is no prior systemic anti-cancer EGFR tyrosine kinase inhibitor therapy, and stable CNS metastasis allowed to the stratification by mutation status, in which X19 DEL and L858R, and race in which Asian and non-Asian communities are involved. We see here osimertinib, which is on 80 mg per oral. It shows a normal value 279, and comparator EGFR TKIs, which is a Gefitinib, which is 250 mg per oral, and second one is Erlotinib, which is 150 mg per oral, and normal value is showing 277. We see the RECIST, which is 1.1 assessment every 6 weeks until objective progression disease. And following the progressive PFS analysis and progression event by RECIST 1.1 were no longer centrally collected. Crossover was allowed for patients in the comparator EGFR TKI who could receive open label osimertinib upon central confirmation of progression and T790M positivity. There is OS, which is a key secondary endpoint. In final OS analysis planned for when approximately death was 318 and event had occurred, and for statistical significance, a p-value of less than 0.0495 determined by O'Brien-Fleming approach was required, and at data cut of 61%, which is 22% in osimertinib arm, and 13%, which is 5% in comparator arm, were ongoing study treatment. We see here baseline characteristics in which we consider sex, age, race, smoking status, CNS metastasis, and WHO performance status, overall disease classification, histology, in which adenocarcinoma or other are involved, EGFR mutations at randomizations on X19 DEL and L858R. We see here the sex, male and female, which who were on osimertinib. We see the data 36 upon 64, and comparators we see data 38 upon 62. Here is median range here on osimertinib is 64, which range between 26 to 85, and on comparator it ranges between 35 to 93. And a CNS metastasis, so data entry which is 19 on osimertinib, and on comparator TKIs it is 23. And WHO performance status, it is on osimertinib 40 by 60, and the comparator it is 42 by 58. EGFR mutation at randomization X19 DEL and L858R, which is 63 upon 37, and which is in both this data is same. EGFR mutations is same. We see the data over here, which is primary analysis of progression-free survival. We see the osimertinib and comparator EGFR TKIs. We see the time randomizations and the probability of PFS. In osimertinib, median PFS month, it shows 18.9, and hazard ratio, which is 0.46. And comparator EGFR TKIs, which shows median PFS 10.2, and hazard ratio which is less than 0.001. Here we can also see the final analysis of osimertinib on median OS and months on 95% CL. Here osimertinib, which is 38.6, and the range between 34.5 to 41.8, and hazard ratio which shows 0.799. There are 321 deaths in 556% at data cutoff, which is 58% of maturity. The conclusion we find here is the flora saw a statistically significant and clinically meaningful improvement in OS, where median OS for patient in osimertinib was extended by 6.8 months. Osimertinib is the first EGFR TKI monotherapy to show a statistically significant OS benefit versus another EGFR TKI. After 3 years, 28% of patients in the osimertinib arm and 9% of patients in the comparator EGFR arm remained on first-line study treatment. Osimertinib presented a favorable and consistent toxicity profile, which despite prolonged exposure. We see the final OS analysis of FLORA, which reinforces osimertinib as the standard of care for first-line treatment of patients with EGFRM and advanced non-small cell lung cancer. There is a data here, a flowchart, which is of National Comprehensive Cancer Care Network. We saw the guideline version 4, which is on 2021 NSCLC. We see here the sanitizing EGFR mutation, which is positive, which is carried forwarded with EGFR mutation discovered prior to the first systematic therapy. We see the first line therapy whenever osimertinib is preferred on category 1, there is progression, and there is also other recommendations like erlotinib, afatinib, erlotinib plus ramucirumab. These all are the other combination which also show the progression. And we see the complete plan systematic therapy, including maintenance therapy or interrupt, which are followed by osimertinib or erlotinib, afatinib, gefnitinib, which also shows the progression, which leads to see in the subsequent therapy on non-small cell carcinoma. Here are real-world evidence of osimertinib in which 3 measures are included. First is follower study, second one is OCI effect, and third one is myconos. Here the first line osimertinib in patient with EGFR mutant advanced NSCLC follower study. The introduction, which is started with osimertinib, we know that this is an irreversible third generation EGFR TKIs demonstrated a clinically meaningful improvement in median progression-free survival, which is of 18.9 months versus 10.2, and hazard ratio shows 0.46, and the range is between 0.37 to 0.57 in the phase of third randomized FLORA trial. Overall survival OS, median OS 38.6 months versus 31.8, and the hazard ratio, which is 0.80, which made the osimertinib as the best treatment option for the patient with untreated EGFR mutant NSCLC or advanced NSCLC. It has been estimated that only 2 to 4% of patients with cancer receive treatment with RCTs, and thus raising the issue of representativeness. Real world have become useful tools to access unique insight in routine oncology practice in the post-marketing setting. Here are key features baseline, in which we see the variable where age median range are covered, which is 68, and the range is between 30 to 88. And we see over here that brain metastasis at the time of diagnosis was present, which is 38 of the 38% of the normal value. And we also see here the stages at the diagnosis, which is on stage 4A and 4B, which shows the data over here is 30, and in 4B, the data over here is 90. And best response to osmaltinib, we see here CRPR, SD, and PD, unknown or elevated or not elevated. The study inclusion and exclusion criteria. In inclusion criteria, first we include age, which is more than 18 years, and histological and cytological confirmed diagnosis of NSCLC. Presence of one or more epidermal growth factor receptor mutation in exon 18 to 21, locally advanced recurrent or metastatic disease in stage 3B and 4 according to 8th edition of TNM classification of malignant tumor. And fifth one, inclusion is eligible to receive first line treatment with the third generation EGFR TKI osimertinib. And exclusion criteria include patients who receive the study drug in clinical trials. The study key points are primary and secondary. In primary, we consider MTTD measured from osimertinib start to the discontinuation for any cause, and the rate of treated related to AEs, and the rate of dose reduction and temporary or definitive treatment interruption due to AEs. We see that TTD is under exploration as a pragmatic real-world endpoint to assess effectiveness of anti-cancer therapy in SCLC and reflect the common practice to continue treatment beyond resist progression, justified by biology of oncogene-directed tumor in which oligoprogression frequently occur, and the favorable safety profile of targeted therapy saw. And in secondary, we see MOS, median overall survival, and median progression-free survival, overall response rate, and disease control rates. Progression pattern to osimertinib in terms of number and localization of metastatic sites, new lesions, and progression related to symptoms. There is a diagnostic therapeutic pathway which include the time frame between diagnostic biopsy, histological report, and the proportion of patient underwent loco-regional treatment, and the type and frequency of rebiopsy and performed at progression. Primary assessment and its effectiveness. The patient with poor PS comorbidities, in which rare EGFR mutations and active brain metastasis were in FLORA trial, which shows outcomes were similar to published data, thus adding to consistency to osimertinib efficacy. There is no difference in PFS, TTD, and OS were noted in elderly patient with comorbidity and less common EGFR mutations. We see the data over here, primary assessment effectiveness. The first is a median time to treatment discontinuation. And the second one data, MTTD in patient with or without symptoms at the time of diagnosis. And third one, which is marked as E, graph show MTTD in patient with less than 3 or at least 3 metastatic sites. TTD appeared to be more suitable endpoint to evaluate treatment outcomes in pragmatic real-world trial. TTD was longer than the post-progression outcomes analysis of FLORA trial, which was on 20.8 months, probably due to a study of population unfit for further therapy or a different therapy for oligoprogressive, and better TTD was associated with fewer than 3 progression sites, which is 0.050, and isolated progression, which is 0.018 compared with oligo or systematic progression. We see data here which show poor treatment outcome for patients with brain metastasis, presence of symptoms, and at least 3 metastatic sites at the time of diagnosis, which suggesting tumor load as a negative or prognostic factor. We see data over here, variable number of cases, smoking status, age, baseline EGFR mutations. We see data like variable, we start from male, which is 45, and PFS data shows 0.098, and p-value is 0.120, hazard ratio 1.753, and OS univariate analysis p-value 0.405, p-value again 0.268, hazard ratio 1.705. So we see data over here about the treatment outcome of patient with brain metastasis with a negative prognostic factor. After a median follow-up of 12.3 months of MPFS was 18.9 months, which is 95% CL, and range between 11.2 to 26.7. And another one, MOS was not reached at the time of data, where cutoff value was 81% of censored subject. Here we can see the outcome and normal percentage, number of percentage. There is CR, PR, ST, and the second one number of percentage so is CR is 0%, PR 73%, SD 23, and PD 4%. Again, we can see a primary assessment data here, effectiveness of osimertinib with MFS in patient with or without brain metastasis at diagnosis, which are seen on the data over graph D, and MFS in patient with or without symptom at the time of diagnosis. We see the data at the point of F, in which time and survival range are given. Real world diagnostic therapeutic pathway, essentially element of evidence-based medicine, and could help clinician in decision of making, and among patient experiencing PD, which is number 44, and firstly 21 cases, which is 47.7% underweight rebiopsy at progression, and tissue biopsy 14 cases, which is 66.7%, and liquid biopsy, which is 6 in number and 28.6%. Molecular analysis was performed in 13 samples, which is 61.9%. Druggable resistant mechanism include the following: MET amplification, AMP N is 4, and MET ampere EGFR, which is N is equal to 1, and EGFR M is equal to 1, and HER2 AMP N is equal to 1. We see the safety data and conclusion. The adverse event, any grade, and G3, G1, G2. The data over here, like there is diarrhea, which show any grade, which is 49, and G3, G4, which is 4, and G1 upon G2, which shows data of 45. And we see a venous thromboembolism in any grade, which is 12. The range is 9.5, and G3, G4 10, and G1, G2, which showed two data over here. And the safety data conclusions, we see in 110 percent, which is 87% experienced adverse event, which is 42, which is 33% of grade 3rd and grade 4. And thromboembolism was the most common, which is 10 in number and 7.9%. In the real world ASTRISE study, grade 3 pulmonary embolism accounted for 2% of pre-treated patients receiving osimertinib. No difference in rates of VT was reported according to ASPS, comorbidity and tumor load. Here we again see the univariate analysis of baseline patient characteristics predicting venous thromboembolism. Here we see the number of cases, grade in number and in percentage, and analysis of p-value, and VT present G3, G4 in number, and univariate analysis p-value. Osimertinib confirm effectiveness and safety in the real world scenario, and there is no difference in survival outcome was observed according to age, comorbidity, and type of EGFR mutation. And the again we start with osimertinib as first line treatment for advanced epidermal growth factor receptor mutation, which is positive on introduction is started with improves after treatment with EGFR tyrokinase inhibitors, which is cytotoxic chemotherapy. Osimertinib was found to be superior to the first generation EGFR TKIs in the terms of overall survival. The current study investigated the difference in efficacy with patient background and the safety of first-line osimertinib treatment in a real-world scenario. Here see the data of study inclusion and exclusion criteria. In inclusion criteria, the advanced EGFR and NSCLC with osimertinib is as initial treatment, and we see a patient concurrently using other anti-cancer agent or undergoing thoracic radiotherapy or undergoing post-operative adjuvant chemotherapy or receiving osimertinib as second-line treatment. Here are showing the baseline characteristics in which characteristics and number in which sex, ELOC, smoking ratio, histology and mutation type and stages of cancer are seen with the number of patient value and data over here are showing. The study endpoint reveals primary and secondary. The primary reveals PFS, and in secondary there is OS and time to treatment failure, response rate, safety and post-treatment, complete response, partial response, stable disease, progressive disease are not evaluated. And in secondary, we also see the objective response rate and disease control rate. Efficacy analysis in primary endpoint PFS. PFS occurred in 182 of the 538 patients. In MFS was 20.5 months, which is 95% CL and 18.6, which is not reached from the normal range. We see the other parameters significantly associated with PFS, where a male gender with hazard ratio 1.99 and malignant effusion in which hazard ratio 1.51, liver metastasis with hazard ratio 1.55, and advanced unresectable cases with hazard ratio 1.71 and 95% CI, and which ranges between 1.04 to 2.82. And with respect to PD-L1 expression, the MPFS was an normal range in patient with the TFS, which is less than 1%. And in 14.7 month, the 95% of CI, which runs between 13.6 to 20.5 with the TPS. Where we see here the normal range in patient with TPS is unknown, and which is 95% CI and 16.9 in normal range. Here we can see also the data of over here, which shows the efficacy analysis and primary endpoint, category, hazard ratio, and p-value. With sex, we include a male with hazard ratio 1.99, and the range is between 1.35 to 2.93. A malignant effusion, yes, which is shown with hazard ratio 1.51. And we also see the liver metastasis, which with hazard ratio 1.55 and 95% CI dense between 0.03 to 2.33. And the stage where the recurrence are more is second, third, or fourth, where hazard ratio was 1.71 and with range was showing 1.04 to 2.82. And p-value source is 0.036. And PD-L1 TPS, here are also data is like less than 1% with hazard ratio 1, and in 1 to 49%, the hazard ratio is 1.66, and more than 50% hazard ratio is 2.24, and in unknown, the hazard ratio is 1.53. Thereafter, treatment discontinuation profile. Here are 44.3% that shows the disease progression, and 25.6% that shows pneumonitis, 16% which shows other adverse event, and 14.2% are considered as progression of other diseases or did not follow up or patient request or doctor judgment. The safety profile and adverse event. We see the adverse event grade and number and median duration of onset. First, started with a pneumonitis in grade. The grade include all grade, like a grade, more than a grade third, which shows the number of 69, and in percentage, which is a 12.8%, and median duration of onset is 56 days. And we see the data over grade 5, which shows 60 in number and 11.2%, and median duration of onset is 53 days. And like that, we also see the all grade more than grade 3, and that show also the data over here, like number is 6 and percentage is 1.1, and all grade which is more than a third, which shows 5 in number and 0.9 in percentage. The conclusion is ORR was 76.2% and DCR was 94.1%. PFS is better with osimertinib than any other comparator EGFR TKIs, which is irrespective of PD-L1 expression. Median TTF was 19.1 month, and the median time from the start of treatment to the onset of AE was 56 days, which ranges between 5 to 565 days. Pneumonitis of all grade occurred in 69%, which is 12.8% in percentage, and grade 3 or higher in 24%, which is 4.5 in percentage, and fetal pneumonitis in 4%, which is 0.7 in percentage. The conclusion is a PFS after first line osimertinib treatment in real world practice was favorable, and the discontinuation rate due to AES 41, 18.8%, especially pneumonitis, require further investigation. So we see the conclusion over here of osimertinib. That shows the PFS first line treatment, which is so the real world practice. The data was very favorable, and start with real world study of patient with EGFR mutated locally advanced or metastatic NSCLC, which is treated with first line treatment with osimertinib. The background started with osimertinib. It is third line irreversible oral EGFR TKIs that potentially and selectively inhibits the
With 5 minutes left, so I think you need to wind up early.
osimertinib. Yes, sir.
We are, I think, touching 8 o'clock. So I think you need to speed up your slides.
Okay. Okay. Okay, sir. Osimertinib was demonstrated efficacy in EGFR advanced NSCLC, including central nervous system metastasis. We see that in background there remain a need to evaluate real world disease characteristics and clinical outcomes of patient with EGFRM. This study reports the demographic and clinical characteristics, which is RWTT and TD and RWTTD of patient with advanced EGFR and SCLC who received first-line osimertinib in the US. A study design which shows a global observation prospective cohort study is ongoing in the US, Europe, and Asia, involves analysis of registry and electronic health record data from country-specified data sources in practice. This US sub-analysis include data from nationwide Flatiron Health electronic health record derived de-identified database, and the Flatiron Health database is compared of de-identified patient level structured and unstructured data, which is curated by technology and enable abstractions. So we see the study is going and follow-up period is planned until June 2023. And for this interim sub-analysis data, which were collected through June 30 in year of 2020. So we see the patient inclusion criteria, which is more than 18 years at the time of advanced NSCLC and advanced in stage 3B and 4. EGFR mutation documented prior to the initiation of first-line osimertinib monotherapy and initiated first-line osimertinib from 1st of April 2018 to March 31, 2020. Here is some study design which shows the index date, initiation of first-line osimertinib on day 0 in exclusion assessment window and patient identification window. Here are baseline covariate assessment window which show the follow-up assessment outcome. We see on January 1, 2011, advanced NSCLC diagnosis start date and patient identification start date was on April 1st, 2018 and on March 31st, 2020, patient identification end date was there, and on June 30, 2020, interim analysis cutoff date was. And so assessment and statistical analysis, so the baseline clinical and demographical characteristics and treatment pattern were summarized using descriptive statistics and Kalpan-Meier analysis were used to generate estimates of TT and TD and TTD. There is RWTT and TD was defined as a time from index date until the date of next systematic therapy or death in the absence of next systematic therapy. So we see the adjusted and adjusted Cox proportional hazard models were used to assess association between baseline, covariate, and clinical outcomes. Here are some socio-demographic characteristics. We see data over here, and here are some data of EGFR mutations. Here is a treatment sequencing. We see in treatment sequencing at the time of interim analysis, it is on 318 patient, which is 58 in percentage remained on first line osimertinib therapy or were lost to follow up, and 103%, which is 18.8%, received second line treatment including PD-1 and PD-L1 mono and combination therapies, EGFR TKIs, mono and combination therapies, and patient-based chemotherapy. We see in 101%, which is 18.4%, died while on first line of treatment of osimertinib, and 26%, which is 4.7%, discontinued on first line treatment. Here are real world time to next treatment or death. Main follow-up time was 9.6 months and median was 17.9 months. And 204 event in which 101%, in which 18.4% is died, and in 103, 18.8% switched to second line of treatment with osimertinib. Here is also in the multivariate analysis, the follow-up variables were significantly associated with RWTT and TD, in which stage at initial diagnosis of NSCLC and smoking status.
Nishant, can we conclude now?
Yes, sir.
Please come to the summary, your conclusions.
So our take-home message is the study provides a real-world insight into the use of first-line osimertinib patient with advanced EGFRM NSCLC based on the first-line data cutoff analysis of the US subpopulation, and the interim with RWTT and TD and RWTTD results support with the effectiveness of osimertinib in this real-world population. Longer-term outcomes will be evaluated in final analysis. Thank you. Thank you, sir.
So, thank you, Nishant, for your extensive, exhaustive, and nice presentation and good take-home messages. To conclude, I'll again say that this is I think new treatments will ever come, and we have to update ourselves according to the availability of the medicines. So, thanks, Dr. Ashish Upadhyay, and all the sports given by Samar, Dhruv, and Ashish. So with this, I conclude and see you again. Thank you. Good night.
Thank you. Thank you very much, sir.
Thank you, sir. Good night.
Thank you, sir. Good night, sir.
Support team, you can end the meeting.